Let us discuss the physiologic classification of anemia. So this is one Harrison table which helps us to classify anemia and get to the diagnosis very easily if you get a patient whose CBC report is showing anemia. So whenever you find a patient with anemia, you should check for two important things. One is reticulocyte count, then another is reticulocyte index. If it is less than 2.5, then check for RBC morphology. RBC morphology is saying normocytic normochromic anemia. If the marrow morphology shows that hypoproliferation, this is diagnosed as marrow failure. And here the damage to bone marrow is because of either infiltration or fibrosis or aplasia or iron deficiency. Sometimes the same picture comes with decreased stimulation. So hypoproliferation with decreased stimulation of marrow production or marrow cells production, of inflammation or underlying metabolic defects or renal disease with RBC morphology of either microcytic or macrocytic anemia. Here, this is labeled as maturation disorder. So bone marrow is working normally, but there is a maturation defect in the different stages of production of RBC. So here it is because of ineffective erythropoiesis that is resulting either from cytoplasmic defects or nuclear defects. The etiology that results in cytoplasmic defects is iron deficiency anemia, thalassemias and sideroblastic anemia. Nuclear defects is what is asked in exams and usually presents with macrocytic picture is folate deficiency, vitamin B12 deficiency, drug toxicity, that is alcoholism also promotes nuclear defects, and myelodysplasia. Talking about the retic index more than 2.5, the precursors of RBCs are more because bone marrow is rapidly proliferating, and that occurs because of acute blood loss. So acute blood loss in the form of hemorrhage can result in anemia. Intravascular hemolysis can also result in this type of anemia, wherein retic index is increased. The reticulocyte percentage followed by retic index is increased. Metabolic defects also can result in increased retic index and anemia. Membrane abnormalities like hereditary spherocytosis, elliptocytosis, ovalocytosis. Hemoglobinopathy can also result in increased retic count. Immune destruction resulting in hemolysis, again immune mediated hemolysis, autoimmune hemolytic anemia can also present with this picture, and fragmentation hemolysis can also result in anemia and with retic count increased.